Hello friends, today we are going to discuss the hepatic encephalopathy and the questions which was asked in DRNB critical care exam June 2022. So the question was pathophysiology of hepatic encephalopathy and intracranial pressure monitor. So hepatic encephalopathy is the complex pathophysiology that remains incompletely understood. Ammonia that has been historically known to be major contribute in the hepatic encephalopathy development. So gut bacteria have the major role in the production of ammonia from urea, that is a product of dietary protein digestion. A normal liver converts ammonia to the urea that will be excreted by the kidney. The skeletal muscle also play a role in clearance of ammonia from circulation via amidation of the glutamate to the glutamate. However, in patients with the cirrhosis and portal hypertension, ammonia cannot be metabolized by liver and is shunted to the systemic circulation and eventually enter the brain by crossing the blood-brain barrier. CLD also causes the other systemic effects such as photosystemic shunting, microbiota dysbiosis, malnutrition, sarcopenia, electrolyte imbalance, gastrointestinal bleeding that results in worsening of hyperammonemia, systemic inflammation and oxidative stress, increased blood manganese, bile acids, and lactate. Consequently, these pathogenic factors lead to the disruption of blood-brain barrier and increased influx of molecules such as ammonia that normally do not significantly cross the blood-brain barrier. After entrance of ammonia into astrocytes, it combines with the glutamate to form glutamine, triggering the formation of reactive oxygen species and swelling of astrocytes, which in turn result in the neuronal dysfunction and hepatic encephalopathy manifestations. Ammonia also causes the mitochondrial dysfunction, disruption of cellular bioenergetic, pH alteration, leading to the more deleterious effect on the brain. It also plays a role in the neuronal depolarization and the hysterexis by causing an increase in neuronal resting membrane potential and in inhibition of outward chloride pump, leading to inhibitory postsynaptic potential formation suppression. So, in addition to the ammonia production, colonic bacteria plays a significant role in hepatic encephalopathy development through other mechanisms. Advanced cirrhosis is associated with decreased bile acid production, disrupted enterohepatic circulation, and conversion of primary to secondary bile acid that results in microbiota dysbiosis. Use of proton pump inhibitors in patients with cirrhosis due to various indications also result in decreased gastric acid secretion that promote the hepatic encephalopathy development through intestinal bacterial overgrowth and translocation. So several precipitating factors have been reported for hepatic encephalopathy development, including infection, electrolyte imbalance, dehydration, constipation, and GI. Now we'll see how to approach this intracranial hypertension or cerebral edema. So after development of ALF, early identification and immediate referral to the well-equipped intensive care unit with liver transplant program should be considered to prevent mortality. Ideally, contact with the liver transplant center should start even before appearance of hepatic encephalopathy, and early identification of at-risk individual is crucial. Initial clinical examination include vital measures, pupillary reflexes, ultrasonography, detailed neurological assessment, as well as lab investigation. Then medical history like comorbidities, medication, precedent suicidal attempts, lab tests such as viral serology, autoimmune antibody, toxicology test, and the liver imaging like ultrasound CT should be collected to identify the potential cause of ALF and to rule out chronic liver disease. The goals of managing ALF in intensive care unit should be to treat inciting event combined with the aggressive management of cerebral edema and infection and to support the failing organ until spontaneous recovery or liver transplantation. Now, assessment and management of encephalopathy and cerebral edema. Neurologic involvement in the ALF might be related to the metabolic encephalopathy, cerebral edema, or both. Furthermore, cerebral edema might not always indicate raised intracranial pressure. So, three critical factors causing the raised intracranial pressure in patient with ALF are systemic inflammation, cerebral blood flow, and hypertension. Regular clinical examination and real-time monitoring, coupled with a good neurological examination, can identify impeding cerebral edema. However, cerebral edema might exist even in the absence of clinical signs, more often at high grade of encephalopathy. Elective and timely intubation should be pursued with the use of control mode of ventilation. Now, the next is invasive assessment of intracranial hypertension. Invasive monitoring of intracranial hypertension is performed by placement of catheter in cerebral parenchyma, epidural space, and subdural space or ventricle. So, invasive monitoring provides the most precise detection of intracerebral hypertension and targeted treatment compared with the non-invasive method, but is associated with the high grade of bleeding complication and does not improve patient outcome. So the use of invasive monitoring also depends on the expertise of the center and can be heterogeneous among the healthcare centers. A 2017 study reported the use of invasive monitoring in 65% of patients with ALS. Now, non-invasive assessment of the cerebral edema in ICH. Radiology has a role in assessing cerebral edema as CT does not have sensitivity needed for detecting cerebral edema. MRI is superior to CT. However, MRI is time consuming compared to CT and is difficult to perform in advanced hepatic encephalopathy. So, what are the bedside assessment of cerebral edema and intracranial hypertension? Non-invasive measures for assessing intracranial hypertension include measurement of optic nerve sheath diameter, pupillometry, transcranial Doppler ultrasound, and continuous EEG. Although the data in the ALF are sparse, the non-invasive modalities can detect the cerebral edema before the development of clinical events and is associated with elevated intracranial pressure. The optic nerve sheath diameter correlate with the increase in intracranial pressure as nerve sheath is contagious with intracranial dura mater, and an optic nerve sheath diameter above 6 mm indicates the raised intracranial pressure. Transcranial Doppler ultrasound measures the pulsatility index in the middle cerebral artery. The pulsatility index greater than 1.2 correlates with the patient mortality and need for liver transplantation. Continuous EEG monitoring can improve the detection and characterization of the cerebral pathology in patients with the ALF and detection of non-convulsive seizure. Apart from this non-invasive measure, monitoring arterial ammonia could also determine cerebral outcome. Baseline arterial ammonia levels of greater than 150 mmol and persistent hyperammonemia during for initial 3 days following admission to intensive care unit strongly predict cerebral herniation and poor survival. Now the management of cerebral edema. Maintaining gentle and less frequent orotracheal suctioning can prevent the worsening of cerebral edema. Frequent and routine measurements of blood glucose is required to prevent hypoglycemia and hemodynamic instability. Deterioration of the brain, if any, must be detected early so that timely and appropriately intervention can be executed. Use of N-acetylcysteine. N-acetylcysteine has a definitive role in paracetamol-induced ALS. So the N-acetylcysteine is a drug of choice for patients with ALS from any cause and has been documented to improve transplant-free survival in patients with the grade 1 and 2 encephalopathy, but not in more advanced grades. So in multi-center survey by European ALF Consortium, N-acetylcysteine was used in more than 80% of patients with non-paracetamol-induced ALS. A systemic review and meta-analysis, which included viral hepatitis and drugs as the most common cause of ALF, reported that treatment with N-acetylcysteine improved transplant-free survival and reduced hospital stay in patients without any effect on overall survival. So N-acetylcysteine is usually given with an initial loading dose of 150 mg per kg per hour over 1 hour, followed by 12.5 mg per kg per hour for 4 hours, and then continuous infusion of 6.25 mg per kg per hour for 67 hours. Now, targeting serum sodium and other elements. Serum sodium level should be targeted at 145 to 155. Hypertonic saline and mannitol can prevent worsening of astrocyte swelling by maintaining serum osmolality and has similar efficiencies in reducing intracranial pressure. However, the rebound increase in intracranial pressure and the incidence of ICAT was significantly higher with mannitol than the hypertonic saline. Hypophosphatemia, it is the marker of regeneration of the liver and should be corrected. In retrospective analysis, serum phosphate level of less than 2.5 was associated with recovery rate of 75%, where serum phosphate level greater than 5 was associated with no recovery. Additionally, the phosphorus replacement was associated with significant improvement in recovery in patients with low and normal phosphorus levels. Now, the drugs for hyperammonemia. Currently, there are no strong evidence to support the use of L-ornithine L-aspartate or lactulose solution in patients with ALF, and these treatments are not recommended. There is also no clear role of rifaximin in patients with ALF. Now, the role of CRRT. In prospective study that delivered CRRT to 24 patients, including 10 patients with ALF, it was observed that high volume hemofiltration strategy with filtration rate of 90 ml per kg per hour and blood flow of 300 ml per minute was more effective in clearing ammonia than slow volume hemofiltration strategy with hemofiltration rate of 35 ml per kg per hour and blood flow rate of 200 ml per minute. Reports by Varillo and colleagues suggest that early, that is initiated within 4 to 6 hours, and prolonged, that is more than 7 hours, CRRT was effective in reducing ammonia level. Reduction in ammonia level correlates with the cumulative duration of therapy in hours rather than hourly treatment intensity. Interestingly, 65% of patients treated with CRRT were discharged alive from intensive care unit at the end of study without liver transplantation. The also literature reported that early initiation of CRRT, that is within 6 hours of admission to intensive care unit, was effective strategy for treating hyperammonemia. Prevention of extreme hyperammonemia was seen in almost 84% of treated patients, which was also associated with transplant-free survival. Taken together, the data suggests that early initiation of CRRT in patients with hepatic encephalopathy and hyperammonemia is effective strategy to improve overall outcome for patients with ALS. So in our experience, preemptive infusion of CRRT in patients with ALS with cerebral edema improves the outcome. Now the next is management of hypothermia, hyperventilation, and decompressive surgery. Preclinical and experimental studies have suggested that induction of mild hypothermia could prevent the development of cerebral edema. Mechanistically, the induction of hypothermia prevents the accumulation of ammonia, glutamate, and lactate in extracellular space, prevents the oxidative and nitrosative stress and osmotic disturbance in the brain, and improves the cerebral vascular hemodynamics. However, a number of reports have suggested a lack of benefit from hypothermia in patients with high-grade encephalopathy. A larger randomized control trial are needed to identify patients who could benefit from this strategy. Mechanical ventilation and hyperventilation to maintain PaCO2 level of 25 to 30 mmHg is suggested for advanced hepatic encephalopathy. Hepatectomy and cranial decompression are measures rarely practiced for treatment of cerebral edema. Thank you, guys.